pleasure and honor to introduce our speakers to this webinar for the COMMeND program that is put together in part through the International Society for Otitis Media. I'm going to briefly share my screen in speaking about the Society for Otitis Media. I just want to remind the group present that the next meeting for ISOM will be in the Philippines. One of our speakers today is from the Philippines, but the abstract's open soon in November of this year, and just mark this on your calendars. June 11th or 14th in Manila. It promises to be a really unique meeting that really is truly a global meeting of experts in the field, and I'm sure this one will be the best to date. So mark your calendars. With that, I'll stop sharing and I'll take a moment to briefly introduce our incredible panel of speakers that our organizing team through Dr. Santos Cortez and Landon, thank you for putting these together, have been able to organize quite the lineup of speakers for today and for the rest of these webinars. This is the third year, I believe, Reggie, correct me if I'm wrong, of this program. And this program comes from an R25, which is an NIH federal grant uh, obtained by Dr. Santos Cortez for the society. This is a grant coming from the U.S. government to aims to expand the network of otitis media researchers through collaboration, building networks and putting together educational opportunities that are truly global in nature. And today is an example of that. So I'm really excited for our webinar today, and we have three great and fantastic speakers, all leaders in the field, not just in otitis media, but in otolaryngology and pediatric otolaryngology. First, my good friend and mentor colleague, Dr. Hermansson, Ann Hermansson, who I don't need to introduce much because she's been a towering figure in our specialty for many decades and has been a presence in our society for a very long time. She has a long history of research in otitis media, developing animal models in rats and experimental acute otitis media studies looking at bacteria, bacterial inflammation, um, middle ear mucosa and reactions to treatments, epidemiologic studies on complications, effects of vaccinations, etc. She's long taught, wrote, and still remains interested in acute otitis media despite all her responsibilities, both locally and internationally. She's been president of multiple otolaryngologic societies in Europe, recently organized and was president for the Congress in Gothenburg, Sweden. It was really a tremendously successful. We were just talking about the amazing program she was able to and meeting she was able to run this past spring. She's also put together and led our European Society for Pediatric Otolaryngologists at the University of Lund, and will be our first speaker today. So, and thank you. Then we also have Dr. Tayyar Kalcioglu. I apologize if I didn't pronounce your last name correctly. Also a renowned and world-renowned leader in otolaryngology from Turkey, who's been or is organizing IFOS, has been a president of and board member of the Balkan Otolaryngologic Headache Association, president of the Turkish National Neurology Cochlear Implant Congress, the German Turkish ENT Society Congress. He's the editor-in-chief of the Medianet Medical Journal, has published well over 200 articles, and is well cited and internationally known with his work in the field. So thank you for being here. And also, and last but not least at all, we have Dr. Maria Reyes-Quintos, who's an otolaryngology surgeon in the University of Philippines College of Medicine, and spent some time in Montefiore and Bronx in New York for fellowship training, has a master in clinical audiology, and at the UP College of Medicine, and earned her PhD in clinical sciences at Radboud University in the Netherlands. So I will turn this over to our speakers, and I look forward to these talks. And shall we start? Anne, are you ready to start? Is that okay?
I'm
I will
prepared.
shut
I'll
my
try to share
audio.
my screen.
Thank you so much. Thank you to
Uh, I said I will start talking about antibiotic treatment because I've ended up working a lot with that after doing a lot of different research, as Diego told you, around otitis media. But it all ended up leading to these things. Uh, Actually, after med school, I started working as a general surgeon in a very small hospital, doing a lot of general surgery on calls, really a lot of trauma, and that was very nice. But at the end, I felt I liked to specialize within the field of surgery, so I moved to a really big university hospital, on the other hand. That's the second biggest in Sweden. It's in Lund, in the very south of Sweden. So I figured I want to do surgery, I want to do research, and I really want to work with kids. So why not ENT? And why not acute otitis media? It's very common. And at that time, a long, long time ago in the 1900s, uh, it was not that cool, actually. So there wasn't so many people interested in it. But it was common, and it was really a problem in the clinic, perhaps more for the general practitioners than for the doctors in the hospital. We know that antibiotics prevented a lot of surgical interventions in otitis media, and that was good. We could kill the bacteria. And actually, before the introduction of antibiotic treatment of otitis media, which really did not start until in 1947, 1950, all over the world, since the Americans had helped the Brits to make penicillin on a larger scale. So in 1940, when we were not treating with beta-lactams, some sulfur, but not much, in Lund, there were more than 200 acute mastoidectomies performed to save the life of people with otitis media. But in 1985, when I came into this, we did something like 20 every year, although we had a 10 times larger catchment area. So it seems that a problem was solved, and it was not a problem for the ENTs any longer. It was more a problem for the GPs prescribing antibiotics. But new problems were beginning to come in the end of the 1980s. There was production of beta-lactamases in Moraxella catarrhalis and Haemophilus influenzae. There was a growing problem with reduced sensitivity to beta-lactams in pneumococci, and there was also chromosomal resistance in Haemophilus influenzae. And when we look back at things, Sir Alexander Fleming, when he was giving his speech at the Nobel Prize ceremony, he said that the thoughtless person playing with penicillin treatment is going to be responsible for the death of those who succumb to infections caused by penicillin-resistant organisms. So already at that time, he realized that we can't just go on this way. We need to take care. And we can see here from this that there was a lot of research going on, and we had the golden age of antibiotics during the 1950s and 1960s, when there were loads and loads of new antibiotics coming into the field, and also in the 70s and 80s. Not so much in the 90s. And of course, there are some new antibiotics coming out now, but we try not to make them feasible for everyone, because then we will end up in the same problem. So at that time, there was a lot of research going on, looking at the effect of different antibiotics. And there was a lot of animal models around where you looked at the effect of different antimicrobials. And there was also a discussion going on, which is the best antibiotics to give for otitis media, and which should we use when we have antibiotic resistance, so what are we going to change to? So they wanted me to start looking at rats, because chinchillas are very expensive in Sweden, and there was a lot of work done in rats looking at the Middle ear mucosa. And there are some drawbacks in rats compared to chinchillas, but there are also some things that are much better. For instance, they don't have a patent tuba, which make it easier to apply to human conditions. So I started working at a rat model for bacterial otitis media. In 1988, I had the first publication, and that was my thesis, was based on these cute animals, where we could operate bacteria into the middle ear and look at what happened. And it actually proved to be a very good model. The rats were actually almost like kids, and it was easy to inspect them, and it was easy to work with them. At the same time, there was problem coming up. The penicillin non-susceptible Streptococcus pneumonia were first found in Australia in 1967, and then we thought it was something extreme, something difficult. But one of the first cases in Sweden we were looking at the end of 1980, and I actually looked at that girl. She was adopted from Poland, planned for heart surgery with a running ear, and when we looked at the bacteriology of that running ear, we found non-susceptible Streptococcus pneumonia. And then it just exploded and was a lot of problems with these bacteria in Sweden for some years. So what do we need? Do we need stronger antibiotics? Should we use the models to look at more effect and more other antibiotics? Or should we perhaps think about what is happening in the world? So I was asked by our professor, as a person who just started doing not so exciting research work on this not so exciting thing with antibiotics and acute otitis media and middle ear mucosa and all these things, to present a paper that was written in the Netherlands. And my boss and my mentor in Lund told me that this is just nonsense. They've started doing something very silly in the Netherlands. They've started discussing, do we really need to treat all otitis media? Of course we do, otherwise people will die. So I got these papers to read them, published in 1981, where 171 children with acute otitis media were treated by 4 different methods. Neither antibiotics nor myringotomy, myringotomy only, antibiotics only, or both antibiotics and myringotomy. All received symptomatic treatment. And there were no significant difference in clinical course. And there was a lot of problems with this paper when you look at it and when you read it now, because the diagnostics were really bad. The GPs were diagnosing the otitis media, and they did not use an automicroscope, and they did not test the mobility of the eardrum and so on. But still, these were the patients that we keep treating with antibiotics. They followed it up with a second paper, Acute Otitis Media, a New Treatment Strategy, where they really applied these results and discussed that most cases of AOM actually was self-limiting and would probably resolve without any treatment. And they looked at 4,860 kids with otitis media that they did not treat. And more than 90% of them recovered within a few days without any treatment except painkillers. So the incidence of acute otitis media and its response to treatment only with nose drops and analgesics were assessed over 3 months by 45 doctors. And 17 months, 60 general practitioners assessed the effects of this limited treatment in children aged 2 to 12 years. And if they were an unsatisfactory course, they were sent to ENTs. And those referred because of appreciable illness continuing beyond 3 or 4 days were entered into a further study where they compared different treatment options. And the course of the condition was only severe in 2 to 7% of the patients. And in these cases, they found group A streptococci in many cases, which were a bit surprising because they are not causing that much otitis media. So the conclusion was that acute otitis media in children can be treated with nose drops and analgesics alone for the first 3 or 4 days. And if they don't recover, they could be treated later on. So how could this work? people died from otitis media earlier, and we were operating them, lots and lots of them, if we look at the old study from 1940 in Sweden. At that time, we also know the bacteriology of these infections. Streptococcus pyogenes was the most common bacteria in these cases. Pneumonia, strep pneumonia were the second most common, and Haemophilus influenza were the third one. So there was definitely a difference to what we see today and what was seen in the 1980s, because at that time, strep pneumonia was the most common, Haemophilus influenza the second one, Moraxella catarrhalis was making up at least 20 or 30%, and group A streptococci were only making up something like 3 or 4% of the cases of otitis media. So we actually had harder to treat, but less sick patients on our hands. We were at that moment working with a rat model, and I will spare you all the mucosal work because only Diego and I are interested in it, although it's extremely interesting. We were also looking at the difference between different bacteria. And we published a lot of papers in this field. Non-typable encapsulated Haemophilus influenza yield different clinical courses of experimental otitis media. So if we looked at non-typable Haemophilus influenza or encapsulated Haemophilus influenza, we got totally different courses in the rat model. We also got totally different mucosal changes. We were also looking at the secretory capacity of the middle ear if we were causing otitis media with pneumococci, Moraxella, non-typable or type B Haemophilus influenza. And we found that there was a major difference in the mucosal changes seen. We were working with that. Dr. Melhus and Per K. Thomassen and I once. And they were bringing me rats, and I was looking at them and writing down how they looked in the ear. And I said, bring on, we start with the pneumococci. And they brought a rat, and I said, this is the wrong rat. You brought me some of the Haemophilus rats. And they said, how do you know? And I said, but I can see it. And then we were all of us very, very surprised, because how could I see that? But we started looking at it, and we actually could differ the different causes of otitis media just by looking at the eardrum. So it wasn't not only the mucosal changes that were different, it was also actually you could see it in the ear. So we did this in people too. So we were looking at otitis media in the operating theater when we could not do it in uncomplicated cases because we were not allowed to do that from the ethics committee, but we could look at those cases where there was a threatening complication. And then we could find that we actually, with the automicroscopic findings, it was possible to distinguish between infections induced by gram-positive bacteria and gram-negative bacteria. Not only in the operating room, but also from photos taken at the time. So there is actually a great difference in different. So otitis media can come in many different customs. So all this was thinking, how about the Dutch way of not treating and with antibiotics in all otitis medias? Perhaps watchful waiting is an idea that should be implied in more places than in the Netherlands. So what is watchful waiting? No antibiotics in the beginning, painkillers, and a new appointment if not better in 2 to 3 days or at once if deteriorating. Today, we can find national guidelines actually promoting watchful waiting in all of these European countries. In some countries, there are no guidelines, but you usually apply watchful waiting. And we haven't seen any obvious rise in complications because at the moment we are looking a lot at what happens when we don't treat all otitis media. And we feel that it is important to keep track of what is happening when we don't treat them all. So we have looked at several different studies, both from our group and from other groups, and there has not been an obvious rise in complications. In smaller studies, in isolated times, there has been a rise. But if we look at complications to otitis media, this is a national study in Sweden where we were looking at from actually for more than 30 years at the numbers of mastoiditis. And you can see that it varies a lot over the years, but there is no obvious change to the worse from when we started with watchful waiting in the year 2000. Looking at the years before and the years after, there is basically no difference. We did not include the COVID years because that was also an interesting worldwide experiment. During the COVID, no one was sick for almost 2 years. And then after the COVID, everyone has been sick. There's been a lot of RS virus, there's been a lot of group A streptococci, there's been more ankylosing group and KNS, worse than ever. And we also looked at that in a Swedish context and could see that there was actually things happening with the kids that had not had their early infections. So we end up with the question to treat or not to treat. But then it's important to consider what we are treating. We need to be better at making a correct diagnosis. And we need to compare the right type of infections, not to compare pears to apples. There are a lot of viruses around, and we need to accept that, and it might be hard to differ, and it's also important to say that there is no effect on the virus infection. There is a synergy in animal models shown very, very nicely by Gibbing already in 1989, where he put influenza into the noses of small chinchillas and found that only 4% got AOM. If you put pneumococci into the noses, 21% got AOM, but if you put them both there, that was 67%. So viruses is very important, but you can't treat them with antibiotics. If we should be able to apply watchful waiting, we need to keep track of the complications because there are still complications. So it's very important to recognize them in a world where we not treat. Most complications are actually caused by group A streptococci or pneumococci, with Haemophilus influenza coming in as a third. And after COVID especially, we have seen a lot of staphylococci and ankylosing groups emerging as pathogens in complications. And they might mess up the symptoms and complicate the treatments, which is very interesting. So what we need to think is watchful waiting is not do not treat. It is a treatment. We should diagnose the AOM. We shouldn't stop diagnosing them. But in most cases, we can wait. In Sweden, we have been able to get everyone on board using this watchful waiting, partly because we have been looking closely at the complications and have been able to show that this is not dangerous. And partly, of course, because pneumococcal vaccination a bit changed the numbers of complications. We could also show in another study that it actually is good for the child, not only for the world, that you don't treat them too much with antibiotics, because the child who gets much antibiotics is at a risk to acquire pathogens with antibiotic problems. So what we need to do is stop thinking what will happen if we use less antibiotics, because antibiotics, of course, lowers the risk of mastoiditis, but numbers needed to treat are 5,000 in unselected cases. So we need to think with a growing antibiotic resistance that is actually hardly related to the use of antibiotics. We need to think what will happen if we don't use less antibiotics. There will be a problem, and there already is a problem in great parts of the world. So we need to think acute otitis media is not just any otitis media. In acute sporadic AOM, in other ways healthy kids, we now start to think that you need to beware of pneumococci and group A streptococci. You can basically forget the Moraxella catarrhalis, and you need to watch the Haemophilus influenzae. In Sweden, we have these red, yellow, and blue that you can look at what is an otitis media. And then we say that otitis media is what is you, if you are sure, if you're not sure, and if you're sure it's not. And then there are recommendations what to do if it is either of them. So a child between 1 and 12 without complicating factors, you can see some of them here, should not be treated with antibiotics in the beginning. But it only applies to healthy children aged 1 to 12 years, and all adults should be treated. And the question is why? And that is because we don't have a documentation telling us that it's safe not to treat adults. There are so few cases reported in studies. We are now looking at studies that might get us closer to this. We also need to be better at recognizing early signs of complications. And we need to realize that we are not all equal, nor can we ever be so. And that also applies to our immune system and our ability to protect ourselves from serious infections. So we also need to look at the person. The time is not allowing me to look at that. We have made some studies around who needs to be treated and who doesn't need, and what happens in the mucosa in different cases. We'll have to do that another time. If we treat, what should we use? It has been shown that as narrow spectrum as possible is good, and as short time as possible. In Sweden, we stick with penicillin V, which a lot of people are very surprised at because they say, don't you have any Haemophilus in Sweden? Yes, we have a lot of Haemophilus, we have a lot of Moraxella catarrhalis, and we don't aim at treating them in the beginning because, as told, pneumococci and group A streptococci are the two main bacteria making problems. So if we know that we treat these two, we can just let Haemophilus and Moraxella go at the beginning. Some Haemophilus are really giving us problems, so then we have to use an antibiotic aiming at Haemophilus influenzae. So our second line of treatment is amoxicillin. And this works well for us. We use a lot of penicillin V. The parents are not always that satisfied with that because it tastes shit, to be serious. But we usually can get people to do it, and it's known in Sweden that you get antibiotics that taste bad, and we have ways of going around that. So we need to treat the disease, but we also need to treat the patient. So we need to look at both the disease and the patient. I've talked much about the disease today. Another time we will have to talk more about the patients. So I think I used my time. Thank you.
Thank you so much, Anne. I don't know if there's questions from anybody in the group. If not, Anne, I was struck by something you said, and I just had a brief question. That is, how could you tell? Could you elaborate on what from the physical findings or physical features of the TM would allow you to predict gram-positive versus gram-negative infection in the model
Yeah,
or in the patient?
Yeah, we were first looking at it in the rats, as that was where we suddenly realized that we could see a difference. We could see a difference in the appearance of the tympanic membrane. We could see a difference in how it was bulging. We could see a difference in how it developed, how fast it developed. This was an acute infection. The more acute it was, the more convincing it was that it was pneumococci, group A streptococci. And there actually was a Danish study done by Myggen et al., where they also could show that they counted the hours from the beginning of the pain to when there was a serious infection. And then they realized that group A streptococci and pneumococci, that was a quick infection, while Haemophilus and Moraxella was slow. And we could see the same thing. And we could also see bleedings in the tympanic membrane, for instance, in the capsulated bacteria. And also it was kind of hard. Sometimes when I go to the emergency room, I make fun and I say, this is pneumococci, and the young doctors laugh at me. And then we take a sample and see if I'm right. And mostly I am. And I sometimes find it very hard to explain. It's like really good radiologists looking at a picture and they say this is tuberculosis, and you say, how do you know? And they say, I can just see it. It's part of what we will teach AI. I think when we can take photos and teach AI to see a lot of pneumococci, and then they will say this is pneumococci, and they will probably be better than I am at it when we have learned to make good photos of the tympanic membrane.
It's fascinating. I think that is very interesting as you correlate to what you found in the mucosal model, where
Hmm.
the the Marxella or the NTHI organisms showed more of a mucosal, right? More of a goblet cell response,
Yeah.
less inflammatory or acute inflammation in terms of the response. And maybe that's, what you're seeing in the patients. In terms of the watchful waiting, do you in using that skill or that intuition, that clinical sense, would you ever consider guiding therapy? Like some child you may be more inclined to treat with an antibiotic versus another one based on your suspicion for the bacteria
Yeah.
that may be affecting the patient? Yes.
I do that. I don't generally tell people that I do it, but when I look at kids in the emergency room, I sometimes just look at them and think this is no use with watchful waiting because this is a group A streptococci, and then I treat them at once. And I usually explain then to the parents that this looks so bad, so we need, because in Sweden parents now don't want antibiotics. They always ask, do we really need to treat this? And we say, yes, this is a case that needs to be treated. And in some cases, you can just look at them and say, yes, this is an otitis media, but it will heal by itself in 2 or 3 days. So I sometimes use that, but you can't sell the argument to the general practitioners that you need to learn to look at kids with otitis media to be able to decide which to treat or not to treat. And we realize that although we showed that 3 competent ear, nose, and throat surgeons that has been working with middle ear and middle ear infections all their life, they can make this differentiate. That doesn't mean that every GP around the country will be able to do it. So we don't try to sell this thing, but we make all these guidelines instead, but they really aim at the same thing.
Fascinating. Yeah, but I wonder if one can teach AI, with all these AI models that
Yeah.
many people are working on that show quite good accuracy in terms of defining the degree and amount of inflammation
The problem
present.
is we are actually conducting a study like that with a GP who's interested in these things. The problem at the moment is getting good enough photos of
Is
the
yeah.
eardrum.
Hmm.
Because the problem is getting good photos of the eardrum. And also the problem is that we are not allowed by the ethical committee to take samples from the middle ear. So we have
Correct,
to
correct.
take samples from the nasopharynx. And we
Right.
have been looking a lot of that in different studies at if you can say that a bacteria that is in the nasopharynx that caused the otitis media that you're looking at. And I mean, there are mostly, if you have kids going to preschool, they have 3 or 4 bacteria in the nasopharynx, and then you don't know which it is. From our studies, where we have done tapping both middle ear and nasopharynx in a lot of kids, we have concluded that probably the worst one is the one causing the otitis media, but you can't be sure about that. So that's a problem when you make uh, the data set for the AI that
Right.
you would like to have a sure, and that is not in so many cases we can do that, especially not in Moraxella and Haemophilus.
Yeah. Well, thank you so much. Any other questions? I don't see any other questions in the chat, but really appreciate that, and thank you so much for that talk. We will move on to our next speaker, Dr. Kalcioglu, um, who we introduced again earlier, and we're very honored and privileged to have him as part of our roster of panelists. So, Dr. Kalcioglu, I'll turn the microphone to you. Thank you.
Thank you very much, dear friends. Let me really good said my last name, Kalcioglu. It is really correct. Thank you. Thank you very much. So today I will present our multi-center cross-sectional study investigating the prevalence of otitis media with effusion and its associated risk factors across a wide geographic region from Balkans to Caspian Basin. And this study was published in the International Journal of Pediatric Otorhinolaryngology. This is my hospital where I am working in. Actually, my room right now, I am talking with you in this area. My office is in this location. So these are my colleagues. I want to introduce them to you because this is like my family. As I told every time, I spent my most time in my clinic than I spent in my home. So they are really my family. These are my staffs here, my residents. Currently I have 30 residents. It is a lot really, but unfortunately I have such kind of big number. These are my audiologists. As an otologist, I have a good chance to have such kind of very, very successfully audiology team together with me. I want to remember you, IFOS Istanbul will be in this September in Istanbul. I am one of the organizing committee member, and we will have translation to all languages, Chinese, Portuguese, Spanish, and the other one, but the official language will be English. So this is what I will perform next year. Unfortunately, at the beginning of this meeting, I heard that also there is Otitis Media Congress almost at the same date next year, but I will perform Fourth Black Sea Countries Otology Neurotology Congress in Trabzon. It is very historical city located in the north part of the Turkey, very close to Georgia. So if any of you want to become a faculty, please go to this website and correct the form. I will be very happy to see all of you. Also, I am the editor of chief in this journal, Medeniyet Medical Journal. We are in Web of Science, PubMed, Scopus, and the other indexes. And also yesterday, we learned our new impact factors in Web of Science. We are 1.5 in Q2 level, and in Scopus we have 2.3 site score. So now I want to run to my presentation. First, I would like to state that we have no conflict of interest and that this study received no fundings. Otitis media with effusion is a very common disease in childhood, especially between 2 and 6 years old. It often present with insidious symptoms leading to delayed diagnosis, thus remains a significant global health issue because these kids do not have any symptoms like ache or a high fever. They only have hearing loss. If the parents are not carefully, or if the teachers are not carefully, we may be delay to diagnose this problem. Sorry. The pathogenesis of otitis media with effusion is not fully understood. However, adenoid hypertrophy and eustachian tube dysfunction facilitate the formation of pathogenic biofilms, which may contribute to middle ear effusion. In our recent study, we also observed differences between adenoid and middle ear mucosa. To note the previous presentation, we tried to see the microbiota of the healthy middle ear. How we did it. I am a surgeon, as you know, and I very like to perform cochlear implant surgery. I do it around 1 year old children. So during this surgery, if there is no any sign or symptoms about the otitis media, I collect some washing water from the middle ear. It means it is almost clean from the infections. And if the kids did not have any history of infection, so we perform study. I am trying to continue to the studies to learn the microbiota of the healthy middle ear of otitis media with effusion cases, adenoid area, blah, blah. So I really like to work on this issue. And it is not an ethical problem. It is not a problem to get ethical approval because I do it during the cochlear implant surgery. So I have to perform something during the surgery so I can collect such kind of materials from the middle ear. Many environmental, socioeconomic, biological, and anatomical factors have been reported, but their relationships are complex and sometimes controversial. As previous studies were conducted in different countries across different seasons using varying protocols and methods. Our aim was to evaluate otitis media with effusion prevalence in the most affected age group within the same season across a wide geographic region, while also investigating the effects of altitude and latitude and to assess all potential risk factors together in the same model in a single study, which has not been done before. The study was designed as a cross-sectional multi-center study. After obtaining ethical approval and official permission, we included centers from 18 centers in 16 countries from Balkans to Caspian Basin. Following power analysis, a total of almost 4,800 children were included. Children were randomly selected from schools across different regions. So we went to the schools, we examined healthy-looking children, and we did some tests and also questionnaire. Then we collect all the data. So I want to show you where we did this study. Let me make bigger. This is here Turkey. This is Balkan region. It covers some part of Ukraine as well, Georgia, and Hazal bases. It cover Uzbekistan, Kyrgyzstan, Tajikistan, Kazakhstan, etc. So we did it almost in this part of the world. All potential risk factors were assessed using a structured and standardized questionnaire across all centers, which was completed by parents or caregivers. Otitis media effusion presence was initially determined based on otoscopic findings and then re-evaluated with additional diagnostic methods, including tympanometry and acoustic reflex. Thus, we aimed to compare the prevalence based on clinical examination alone and the prevalence using combined diagnostic methods, allowing interpretation of diagnostic accuracy. So we firstly perform otoscopy, then we did tympanometry, and we did otoacoustic reflex evaluation. Descriptive statistics were used to summarize the data. Agreement between diagnostic methods was assessed using kappa analysis. Multivariate logistic regression was performed to evaluate multiple risks factors simultaneously and due to collinearity among geographic variabilities such as altitude, latitude, and country. Two separate models were constructed. First, we evaluate the agreement between diagnostic modalities. Agreement between clinical findings and tympanometry was statistically significant but moderate. Most patients, over 80%, without clinical otitis media effusion had normal tympanometry, while type B was more common in bilateral cases. Similarly, agreement between clinical findings and acoustic reflex was also statistically significant but moderate. You see our summary of our results over there. When prevalence was calculated based on otoscopic examination alone, it was almost 22.5%. However, when tympanometry was included, it almost halved and dropped to almost 11%. And with the addition of acoustic reflex, the prevalence decreased even further to 5.6%. This indicates that otoscopy alone may overestimate the true otitis media with effusion prevalence. Then all potential risk factors were evaluated simultaneously in our study. Only these remained significant. These could be grouped into three main categories. Child-related factors included younger age and recent upper respiratory tract infections. Parental and household factors included paternal smoking, low maternal education, and maternal occupation. And finally, we observed significant differences between countries. I want to give attention that we have to stop smoking in the house and around the children. It is really very important factor to see otitis media with effusion in the children. We evaluated altitude and latitude effects to better understand the country differences. For altitude, although prevalence appeared to vary between groups, we found no statistical significant association. Similarly, for latitude, prevalence seemed to be higher around 41 degrees and lower at other latitudes. But again, this difference was not significantly important according to our results. Our study is a large-scale, multinational, multi-center study resembling a meta-analytic approach, evaluating otitis media prevalence and all potential risk factors under standardized conditions. To the best of our knowledge, this is the first study of this kind and scope in this field. Therefore, our findings may provide a significant contribution to the literature according to us. Diagnostic variability clearly affected prevalence. Remember the prevalence pyramid when I showed you some slides before. As the number of diagnostic modalities increased, the estimated prevalence decreased. Therefore, objective methods such as tympanometry and acoustic reflex testing should be included to prevent overestimation and obtain more accurate prevalence data. The wide range reported in the literature from 2 to 62% may be explained by the use of subjective diagnostic approaches and study designs in different regions. When interpreting previous studies, these factors should be taken into consideration. Therefore, standardization of diagnostic criteria is essential. We observed that agreement between diagnostic modalities increased with age. Younger children may be more prone to diagnostic variability, like due to difficulties during examination related to lower patient compliance. In addition, the relative immaturity of the eustachian tube may also contribute to this variability. As children grow older, findings become more consistent. Otitis media with effusion has a multifactorial nature, and we identified several associated risk factors. Among these, country differences have significant effect on prevalence. When we evaluated altitude and latitude effects, they did not show a clear association with prevalence. The differences observed across countries are more likely related to lifestyle and cultural factors rather than geography itself. We can conclude that geographic factors alone may not explain variability. However, as our study was performed across countries with relatively similar latitude, further studies are needed to better understand this relation. Previous studies in the literature mostly relied on univariate analysis or descriptive statistics, and multivariate models were rarely used. In addition, most studies were single-center studies. On the contrary, in our study, univariate analyses were used only for variable selection, and the effects of risk factors were evaluated using a multivariable logistic regression model. And this is my last slide. In conclusion, otitis media with effusion is a multifactorial condition influenced by both children-related and household factors. We identified several associated factors, including younger age, recent upper respiratory tract infections, paternal smoking, maternal education, and occupation. Interestingly, differences between countries seem to be related more than lifestyle and cultural factor rather than geography itself. This large multicenter study provides robust data across a wide geographic region, and these findings may help improve early identification and management of children at risk for otitis media with effusion. So thank you very much for your attention and give me a chance to talk together with you in this platform.
Thank you so much for that talk and that project. That is very interesting and fascinating. You were able to do wonderful, beautiful pictures. Question, I don't know if there are any questions from the group, from the audience. I had a question, Dr. Kalcioglu. Uh, Vaccination rates or penetration of vaccination for pneumococcus across the multiple countries and geographic regions, are they similar? Are you able to control for those, or the variability in the vaccination?
Actually, we in our region in this area, in the vaccination protocol, we vaccine to all the children with pneumonia and Haemophilus influenza. So maybe that's why we could not say anything, because all of them are vaccinated. So I cannot compare without vaccinated children, because
Right.
they are all vaccinated.
Good. Reggie.
Hi, that's really fascinating, and it's nice how the two talks complemented each other. So, my question is regarding imaging and diagnostics, because it seems like one point that both of you raised, that you can improve the otoscopic diagnosis if you had better imaging and if you had additional tests like TIMPs and acoustic reflex. However, there is concern that there's already rising costs of healthcare. So if we develop new diagnostics that might be more expensive, especially for GPs and pediatricians to implement, what are your thoughts on this as new technologies become more available to some?
Yeah, actually, during this study in Turkey part, I went to the schools together with my team, and I examined all the ears myself. So I think there is not any problem about the diagnosis as otitis media with effusion. But it seems that really we can decreasing the real examination, how can I say, diagnosis by using tympanometry or and plus otitis plus reflex. So even if I am very experienced one, I did such kind of misdiagnosis. It means we have to put in this kind of studies about the more laboratory tests like tympanometry or reflexes. So we have to work on it. So even if they are very expensive instruments, so we have to put them into the diagnostic period. Not only examination is not enough for me. Sorry because of my English, but I think you can understand me.
Absolutely. It was fantastic. I totally agree. I mean, I think something that we don't often discuss or recognize is the challenges, particularly in younger children with small ear canals and getting good exam, as you mentioned. And even when we have innovation and tools that may be expensive, that are equally hard to use in small children, it's a factor. It's definitely a factor that needs to be considered and worked around. Um, are there any other questions? Suchana, I think the cost of proper diagnosis is weighed against the cost of unnecessary antibiotics and their complications. That's a very good point. Absolutely right. It's absolutely true. No doubt about it. And I think there's room for improvement. Any other questions from the group? Thank you, Dr. Kalcioglu. I'm sure IFOS is going to be phenomenal. There's a lot of enthusiasm for the meeting coming up in Turkey. And so congratulations on that.
Thank you. Hope to see all of you in Istanbul.
Yeah. And so we will turn this over now to our next speaker, Dr. Maria Reyes-Quintos from the University of Philippines. We're honored to have you as part of this distinguished panel. Thank you for joining the ISOM webinar series. We'll turn the microphone over to you. Thank you.
Good day, everyone. I'm very honored to speak before you today about otitis media, the Philippine situation. For this lecture, I have nothing to disclose. For my outline, I will introduce you first a bit to the Philippines to give you an idea of its life and health situation. Then I will discuss some studies on the Philippine prevalence of otitis media, including CSOM and AOM, then talk about OM in specific populations, in the indigenous population in particular, and tuberculous otitis media. So let's start. So the Philippines is officially the Republic of the Philippines. It's an island country of Southeast Asia in the Western Pacific Ocean. It's an archipelago consisting of 7,000 islands and islets lying about 500 miles off the coast of Vietnam. It is known for its tropical islands and diverse marine life. Manila is the capital. The population is 117.7 million, making it the 14th most populous country. The Philippines has a service-based economy with strong remittance flows. It is divided into 3 island groups, Luzon, Visayas, and Mindanao, and Manila is in Luzon. It is also the home of many populations. Of interest is the Ati in Boracay, which is the basis of some of the genetic studies on otitis media by Dr. Regeline Santos Cortez. The Philippine situation needs a lot of improvement, but good changes have been happening that makes me a bit more optimistic about our situation. We have the health benefit package or coverage for common diseases, as well as the Philippine health insurance for all Filipinos. We also have the construction of tertiary government hospitals in strategic areas in the Philippines. But at this point in time, we still have overcrowding in the outpatient department, in the emergency room, lack of inpatient beds in hospitals, and our fellow men still have difficulty accessing healthcare. A letter written in the Journal of Preventive Medicine and Public Health in 2022 identified the reason for our present situation, our poor health care system, and it's due to problems with leadership and mismanagement of the budget. Now let's see the publication and related studies on the prevalence of otitis media, acute otitis media, and chronic suppurative otitis media, and tried to compare it to other countries in the world. But before that, this slide shows us that otitis media encompasses a spectrum of middle ear conditions from acute otitis media to otitis media with effusion and chronic suppurative otitis media. First, we start with otitis media. A study published in 2025 described the global, regional, and national epidemiology of otitis media in children from 1990 to 2021. Results showed that the prevalence was 14.8%. Regionally, the highest age standardized prevalence of otitis media was observed in Eastern Sub-Saharan Africa, South Asia, Western Sub-Saharan Africa, while Central Europe, East Asia, and high-income Asia Pacific exhibited the lowest prevalence. Key risk factors identified included secondhand smoke, particulate matter pollution, low birth weight, and short gestation. We compare this with another study published in May 2012 with a more specific prevalence of otitis media involving the Asia Pacific, and here, otitis media prevalence in the Philippines was noted to be 12.23%, a little lower than the global prevalence. They also included otitis media with effusion prevalence and CSOM prevalence data, but we will discuss this later. Thus, for otitis media, the prevalence in the Philippines is 12.23% compared to the global prevalence of 14.8%. The higher prevalence was reported in children with hearing impairment, HIV, pneumonia, and rhinitis. OM prevalence and incidence and service utilization were highest in children 2 to 5 years of age. Now, with regards to the prevalence of acute otitis media, a study in Portugal showed that 34.8% of young children between 1 to 4 years old had acute otitis media. While in the Philippines, a study done in 2013 showed a prevalence of 9.65% among 0 to 12 years old. The reason why the prevalence is lower might be because of the wider age range in the Philippine study. They also concluded that there is no gender predilection, with the 0 to 2 age group having the most prevalent cases of AOM in the sample. Going back to the previous study on a review of the burden of disease due to otitis media in Asia Pacific, strep pneumonia and H. influenza continue to dominate as primary causes of AOM, and they concluded that AOM may be prevented by vaccination. In 2024, a study published in The Lancet was conducted in Bohol, Philippines. In this study, administration of 11-valent PCV in infancy was associated with absolute and relative risk reduction in the sequelae of acute otitis media. Thus, for AOM, Philippine prevalence based on the single study is 9.6% compared to Portugal, which is 34.8%. Strep pneumonia and H. influenza dominate as primary causes of AOM in all studies, and administration of 11-valent PCV in infancy is associated with absolute and relative risk reduction in sequelae of acute otitis media. But how about otitis media with effusion? Unfortunately, I have found no studies on the prevalence of otitis media with effusion in the Philippines so far. So these were the publications that I was able to take note of. And you can see that this includes the study recently presented by the previous speaker. So we also have from Vietnam, Malaysia, Nepal, and of course the Balkans to Caspian Basin. Now let's go to chronic suppurative otitis media. In 2004, Dr. Akuin worked with WHO and published the manuscript Chronic Suppurative Otitis Media, Burden of Illness and Management Options. This showed that the Philippines has a high CSOM prevalence of 2 to 4%. Next, I would like to present our Philippine Regional Census. This is our study that was presented during the 15th Asia-Oceania ORL-HNS Congress in Brisbane, Australia in 2023 on the topic of ear disease across Asia-Oceania. Before I present the census, I would just like to show this interesting published paper in 2022 by Pardo Patrick Joseph entitled Hearing and Clinical Otology Profile of Filipinos Living in Southern Tagalog Region, published in the Philippine Journal of Otolaryngology Head and Neck Surgery, which showed that 35% of patients who underwent a hearing test had chronic suppurative otitis media. However, we cannot generalize this to the general population because this is a sample with selective bias. The Southern Tagalog region, also known as Calabarzon, is found also in Luzon. Next, we have the census in the Philippine General Hospital, which is the largest tertiary state-owned hospital in the Philippines, designated as the National University Hospital, also located in Luzon. It has 1,500 beds, receiving and serving patients from all over the country. We were able to retrieve data from 2013 to 2022, and the census here shows that before 2020, there was an uptrend in CSOM cases being seen at the outpatient department, being operated on, and being seen in the emergency room. We had wanted to segregate them further into the final diagnosis at the outpatient and emergency room setting and the type of surgery performed. However, there was no uniformity in the data, and so this was not done. Next, we have the Corazon Locsin Montelebano Memorial Regional Hospital. This is located in Bacolod, in the Visayas. It is the biggest government hospital with 400 bed capacity. Their census before 2020 shows increasing CSOM outpatient consults and ORs, and similar to PGH, a subsequent decrease after 2020. The COVID-19 pandemic certainly affected the census in these hospitals from 2020 to 2021, when both hospitals became a COVID referral center, when admission of COVID patients were prioritized over the usual cases. However, decrease in COVID cases from 2022 to present should have brought the cases back to the usual number, but it did not. We will observe this trend for further developments. We also wanted a census from a recognized institution from the Mindanao area. Unfortunately, they were not able to submit their census. To try to explain these results from PGH and CLM-MRH, and also to determine the experience of other otolaryngology head and neck surgeons about CSOM, a survey was sent to the fellows of the Philippine Society of Otolaryngology Head and Neck Surgery, and these were the results. Majority were general otolaryngologists, practicing for about 11 to 30 years. Majority of those who answered resided in Luzon. And when asked about the number of patients with COM that they see in the clinic now compared to before practice, 34% said that it was decreasing, 32.7% increasing, and 30.9% said it was the same. So more or less equivocal results. When we ask, what can you say about the severity of patients with CSOM that you see in the clinic now compared when you started your practice? 55.6% said that it was decreasing, 31.5% said the same, and 13% said increasing. So for this question, majority said that the severity was decreasing. When asked if there was a difference in the way they treated CSOM during the early part of their practice compared to present, 50.9% said yes. When asked for the reason for this difference, 19% attributed this to the effectiveness of medical treatment, and 14% attributed this to new studies, training, and technology. For the 22% who answered none of the above, they were given a chance to explain, and the majority of them attributed their change in treatment to improved healthcare and patient education, use of clinical practice guidelines, and better diagnostic procedures. So for the prevalence of CSOM in the Philippines, I bring back the slide of WHO in 2004 on chronic suppurative otitis media, which says that the Philippines has a high CSOM prevalence. And for the otolaryngologists, although the cases are relatively the same number, the severity of the cases seem to be less. Now for the OM studies involving our indigenous population and tuberculous otitis media. The Philippines, as was mentioned previously, is also the home of several indigenous communities, and one in particular that we studied is the Ati community in Bolabog, Boracay. The Ati are said to be descended from the first habitants of the Philippines. Traditionally, they were semi-nomadic hunter-gatherers who roamed the island in small bands. They are characterized physically by dark skin, finely curled hair, and short stature. Several research publications have been made involving this community, and the results show that the Ati population in Bolabog, Boracay belong to the group with the highest prevalent rates in CSOM, about 27 to 50%. This is also where Dr. Regeline Santos Cortez identified the presence of the rare A2ML1 variants, the FUT2 variants, and the SLP1 splice variant, all which confer otitis media susceptibility in the indigenous community. So I'm glad that Dr. Reggie is here with us so that if you need more details about this publication, she can provide you with the answers. Next, we have tuberculous otitis media. In 2024, 8 countries accounted for 2/3 of global TB cases. There's India, Indonesia, China, Pakistan, Nigeria, the Domestic Republic of Congo, Bangladesh, and the Philippines, accounting for 6.8%. Although the incidence has supposed to be decreased by 5% in 2025, it is still an entity that should not be disregarded, especially for OM cases that would not resolve despite proper medical and surgical treatment. A study done in 2023 by Dr. Abes et al. In the Philippines and published in Acta Medica Filipina showed that TB otitis media was not only found in chronic cases, but also in acute cases with the use of PCR and biopsy. The study also mentioned that tuberculous otitis media is difficult to diagnose because of its rarity, varied presentation, and lack of distinguishing clinical features. It is also found in 1% of CSOM cases. In summary, this is the prevalence of AOM, OM, and COM in the Philippines compared to other countries. This shows that even though we have a relatively lower number of AOM and OM, maybe because of the possible delay in health service provision, lack of resources or knowledge, it progressed to chronic suppurative otitis media. Vaccination may help prevent AOM, and also that TB, otitis media, is a disease entity that we still need to be aware of, especially in countries where it is commonly found. Thank you very much.
Wonderful, wonderful talk to hear about the Philippine situation and how it can inform our understanding of the disease. Incredible work, Reggie, to see all those papers cited with this collaboration. I know there was some collaboration, but that's pretty amazing. Pretty amazing. I don't know if there's any questions from the group.
Just a comment. It was actually Dr. Rina who spearheaded that project in that island. So
Fantastic work.
We owe that to her.
As you know, Reggie and Dr. Reyes, I think the work that shows the susceptibility in the genetic profiling is really critically important and paramount to our understanding of otitis media in general. So the fact you were able to use a high prevalence population to identify an association in a gene of importance for immunology, like FUT2 and a glycosylation gene. I just wanted to ask about the population that was that a population of patients that had acute otitis media susceptibility or CSOM? And in hearing the talk, it seemed like it came from a group of CSOM patients, perhaps. And if so, how do you think how does it correlate in other patient populations I know you guys have studied?
Is this the one, the ATI population?
Yeah.
They were relatively a small community with intermarriages. So we took a look at all the ears, all the patients that were available. We tried to get all of them to check their ears.
Okay.
So it was actually kind of a surprise that CSOM was very common. We didn't know that it would be common. Yeah.
And is the gene association that you have found with the FUT2 and other genes even more stringent when there is CSOM? When the disease progresses from AOM to CSOM? Do you know the answer to that question? Either you, Dr. Reyes, or Reggie?
Reggie, would you know the answer to that?
So we looked also at some of the longitudinal profiles because we were able to see some of the patients at least 4 times. Over time, as we were at the time, but we were visiting the island before funding ran out. After several treatments, that the number of CSOM cases actually stabilized to around a quarter of the population that we studied. And it seems like all of the variants that we identified were associated with the full spectrum of otitis media. So at any, depending on the age or when we saw them, they could exhibit any of the different types.
And your hand, the question?
I think it's extremely interesting with the relation between acute otitis media and CSOM. We have been planning to look a bit at that, but we have too few cases of CSOM in Sweden. And almost all the cases we have are not domestic. They are in immigrants moving to Sweden. So we have been planning to look at it in Greenland, where they have a lot of them. So I think it would be interesting also if you have any clue to how treatment or follow-up of acute otitis media would affect the number of CSOM? Because it's interesting that you see few acute otitis media, but a lot of CSOM.
Yes, yeah, that it seems like the prevalence of and otitis media are not as high as we would think compared to the CSOM prevalence. And maybe that's because, like we mentioned, the lack of funds, or they couldn't seek treatment from the beginning, from AOM treatment, and so that it progressed to CSOM. Another thing is that some Filipinos think that it's normal to have a draining ear.
Yeah.
So they think that it's no big deal. It's found in all children. So they do not seek consultation. So it's not part of our the numbers of children that we see. So it might even be actually higher, except that we are not seeing them. They're not consulting, or so that's one thing.
Yeah, that's exactly what we have been speculating in, because when I started out doing ENT, we had a lot of chronic CSOM in Sweden, in Swedish people. But then when antibiotic treatment started to kick in, they just disappeared. So we felt at that time that it was before people got to the doctors, then there was a lot of CSOM. But when people started to go for discussions and treatment, then it's sort of faded out. So that's really interesting that you see basically the same tendency.
Interesting. All right. Any other questions or comments? If not, I would like to personally thank, each of our panelists and Maria, Tayyar for a wonderful webinar. And congratulate Dr. Santos Cortez for orchestrating these, Landon for administering them, and always making sure that it runs smoothly. So thank you to everyone who attended. These will be memorialized on the website. And this has been a real treat early morning here in Washington, D.C. But thank you to all. Reggie, I'll let you get the last word.
Oh, I just want to thank all our friends for coming over and giving these talks, and we'll try to spread the word. This is a great session. And Lynn is also here. Hi, Lynn. She already agreed to also give a talk about Singapore at a certain date.
Yeah, hi everybody. It's great. I'm so happy to see all of you here. I just wanted to maybe just have one chime in with one thing. I think the OME incidence looks low. It's because people don't pick it up because it's not painful, it's not discharging, and so I think it's actually very high. So I think when you come to a CSOM, it's easy to recognize, and everybody's alarmed, so they get treatment. So I think it's like the OME incidence being so low is not real. Yeah.
It's great to hear your voice, Lynn. Super cool.
I know it's very early for you in the West. Yeah, so thank you.
Yeah, oh, you're welcome. All right. Well, thank you so much to everybody. Reggie, thank you.
Thank you.